Welcome. This program is one in a series of 8 webinars that have been captured to help brain injury survivors, caregivers, educators, healthcare professionals, and other community stakeholders better understand brain injury and provide support to those who are living with the aftermath of brain trauma. This series of presentations was originally designed to help parents and educators assist children and youth with brain injury successfully transition back into their school environments. While many of the examples and references made throughout the presentation are school-centric, the overall content has proven very helpful and relevant to most families coping with brain injury. The content of this webinar presentation specifically focuses on challenges after brain injury. I am Fran Moon, pediatric neuropsychology consultant and school psychologist, and I'm delighted to present this program to you today. This webinar series has been created thanks to the professional expertise and volunteer efforts of members of the Georgia's Brain and Spinal Injury Trust Fund Commission's Children and Youth Committee. The Brain Injury Association has also been a collaborative partner in this effort. The production of this program was funded thanks to an Avenues of Service grant from the Rotary Club of Gwinnett County. We are grateful to everyone that has played a part in making this programming possible. We've got lots of valuable information to share with you, so let's get started. We have the following goals for this presentation: to understand the immediate and delayed effects of brain injury, to understand the most common consequences post-brain injury, to understand how brain injury impacts an individual's physical, cognitive, emotional, behavioral, and psychosocial functioning, to increase awareness of common myths associated with brain injury. Behavioral, cognitive, and psychological changes occur as a result of a head injury. However, the impact varies for each individual and are partially dependent on pre-injury personality, psychological adjustment, intelligence, age at injury, and learning style. During this presentation, characteristics which are considered common with brain injuries will be described. However, these characteristics should not be presumed universal among brain-injured individuals. Many physical, physiological, and neurological changes occur as a result of a traumatic brain injury. Some of the more dramatic early effects are due directly to the changes in the brain and may last for several weeks. Some of those include coma, motor problems, alteration of affect, memory disorders, and post-traumatic amnesia. Some of these symptoms that are noted right after the injury are due to secondary effects of the brain injury, and as soon as these secondary effects subside, rapid positive changes may be seen in the child's condition. This early rapid recovery may cause family and friends to have false hopes that long-term recovery will be more rapid and complete. However, it is very important to remember that early rapid recovery is not an indication that long-term recovery will continue to be as rapid and to be complete. According to a major neuropsychological framework for brain functioning, there are 3 functional units of the brain whose participation is necessary for any mental activity. The first functional unit is responsible for regulating cortical tone and maintenance of attention. The second unit receives, processes, and stores information. And the third unit programs, regulates, and directs mental activity. The first functional unit, the arousal unit, is the most basic level of processing and is associated with the lower brain units, brainstem, reticular formation, and pons. This level of processing is associated with arousal, consciousness, and activation of cortical functioning. Level of arousal ranges from a coma to appropriate levels of alertness. If this level is not functional, cognitive processing does not occur. The second functional unit, the processing learning unit, is responsible for receiving, processing, and retaining information a person obtains through the external world. It has to do with taking in information from the senses, like seeing, hearing, touching, etc. A person has to receive the sensory information before the information can be used. Parts of the brain associated with this include the cerebral cortex, the temporal lobes, the occipital lobe, and the parietal lobes. The third functional unit, production planning unit, allows the individual to form plans of action, carry them out, and verify the effectiveness of plans. The third functional unit relies on the second functional unit for processing components and the first functional unit for proper attentional status. The cerebral cortex is involved in this area, mainly the frontal lobe. When considering challenges post-brain injury, it is important to keep in mind the impact of each of these units on performance. If a child is experiencing difficulties with reading, it makes a big difference if the problem is due to difficulties visually attending to all the letters in the word, or if the problem is due to blending letters to make sounds. Much of the physical consequences of brain injury are associated with injury to the arousal and processing units of the brain. Motor problems can be quite varied, involving injuries to the complex motor systems of the brain, spinal cord, and peripheral nerves. Movement problems may include poor balance, difficulty planning and carrying out movements, which is apraxia, poor coordination, which is ataxia, or unstable muscle tone, spasticity. The sensory systems, touch, vision, smell, hearing, and taste, are as complex as the motor system. Brain injury may cause a variety of changes to any of these senses. Heightened sensitivity to touch results in a phenomenon known as tactile defensiveness. Vision problems following a brain injury are very common. One study reported over 50% of children who experienced a brain injury had one or more problems with vision. These problems commonly include double vision, visual field deficits, or problems with depth perception and visual acuity. These visual impairments usually are not permanent, but improve quickly with most children during the first 6 months. Changes in auditory, olfactory, and gustatory senses may also occur. The nerves responsible for smell and taste are particularly vulnerable to damage during trauma, and many brain-injured individuals report loss of these senses. In the area of speech, difficulties pronouncing or articulating words may occur, and difficulties with volume when speaking may result from subtle breathing problems and injuries to the nerves of the vocal cords. Fatigue and endurance issues following brain injury are a hallmark of brain trauma, and it occurs in several ways. The primary source of fatigue is cognitive fatigue, and it is a direct result of disrupted pathways in the brain as a result of shearing and tearing of axons during brain injury. Once axons in the brain are broken or stretched, immense effort is required to complete even simple tasks. Headaches are another medical problem commonly reported following traumatic brain injury in children. Studies have shown that almost a third of the children report headaches during the first year following a traumatic brain injury. Children who've experienced a traumatic brain injury are also more likely to develop seizures than non-injured children. Approximately 5% of the children who have had a serious traumatic brain injuries develop seizures. These seizures, referred to as post-traumatic epilepsy, can usually be controlled by medication. For the first year following a traumatic brain injury, the majority of children are placed on anticonvulsive medications to prevent seizures. Children with traumatic brain injury usually suffer a decline in intellectual functioning following their injury. The degree of this decline is often related to the location and severity of the injury. However, studies have shown that there is improvement on measured IQs up to 5 years following the injury. Cognitive deficits vary in intensity across students with traumatic brain injury, but typically include deficits in attention, information processing, memory and learning, and problems with problem solving and organization. For educators, the implications of cognitive impairment in children with traumatic brain injury are significant. For a child who returns to school following a brain injury, there may be significant differences in the degree of general comprehension and problem-solving abilities exhibited. In addition, children may demonstrate regression in skills from previous levels and may be unaware of these losses. Also, children with traumatic brain injury will likely display more marked variations in intellectual abilities, with greater variability among areas of cognitive functioning than children without, rendering full-scale measures of cognition less meaningful. Children who sustain traumatic brain injury initially demonstrate motor speech function problems, but those recover rather quickly, often creating the impression of normal communication functioning. However, expressive language impairments and disorders of written language are long-term impairments that interfere with successful school performance. Young children show relatively greater language impairment than adolescents because their language skills are developing around the time of injury. Difficulty with sustained attention over lengthy periods is common within the population of students with traumatic brain injuries. They may be unable to attend to two tasks simultaneously, such as listening to the teacher and taking notes. They may have more trouble attending to auditory information than to visual. After brain injury, the visual spatial abilities are frequently more impacted than verbal and tend to remain at a lower level after recovery. Visual spatial difficulties include copying figures, constructing block designs, and facial discrimination. Speed of visual processing and visual motor skills have also found to be sensitive to brain injuries. Students with traumatic brain injuries may process visual and/or auditory information more slowly than other students in the class. They may still be working on what the teacher just said as the rest of the class is moving on to a new idea or topic. When an individual sustains a brain injury, the abilities that come back most quickly and strongly are those that were securely established before the injury. One reason for this is that after something is learned, practiced, and remembered, it is stored in many different parts of the brain. When individuals try to recall it, they have several different avenues to try. If for some reason the usual approach fails, the information can be accessed in another way. In order for information to be encoded into memory, certain pathways and centers of the brain must be activated. These centers are very vulnerable to being injured. Following brain injury, learning will be most efficient if it occurs in a multisensory or multimodal fashion. Difficulties with executive functioning are frequently noted in children post-brain injury. Executive functioning skills are cognitive abilities necessary for complex goal-directed behavior and adaptation to a range of emotional changes and demands. Executive functioning includes the ability to plan and anticipate outcomes and to direct attentional resources to meet the demands of non-routine events. Many conceptualizations of executive functioning also include self-monitoring and self-awareness, since these are necessary for behavioral flexibility and appropriateness. Students with a brain injury often experience difficulties beginning tasks in a timely manner. It may appear that the student is uninterested or unmotivated or even oppositional, when the reality is they're just having a difficult time figuring out how to get started. Also, developing a plan for a task completion is a problematic area. Planning involves identifying and completing the steps necessary for a task or goal completion. Plan also includes determining the amount of time it's going to take to finish a task. Furthermore, the problems with mental flexibility are common. Mental flexibility means you're able to change the approach to a problem to solve a task. Reasoning is another area that children with brain injuries struggle with. Reasoning involves the consideration of evidence and drawing of conclusions based on the exploration of all possibilities. Changes in emotional, social skills, and behavior are common following brain injury. These changes may be organic or they may be an emotional response to the changes brought about by the injury or both. Impulse control is frequently reduced by injury to the brain. Added to this may be frustration over failing at tasks that once were automatic or dealing with an environment that is overwhelming. Orientation and alertness are also disturbed following traumatic brain injury, particularly during the initial stage of recovery. Most children with a traumatic brain injury, especially those with moderate or severe injuries, experience a period of fluctuations in arousal, as well as disorientation, overstimulation, confusion, and memory loss after an injury. Many of these behaviors arise from physiological factors that can be addressed by changes in the environment to avoid disinhibited behaviors, overstimulation, and increased levels of frustration. Following injury, the brain is generally not as alert and is not able to sustain, focus, or filter out sensory information. Combined with mental effort of using the injured pathways and now challenging tasks of shifting external focus from one thing to another, many students have problems with attention and concentration. There are many types of attention abilities. Sustained attention is the ability to maintain attention over time. Selective attention is the ability to focus on what is the most important thing while ignoring competing stimuli and information from the environment. Shifting attention is the ability to maintain focus while change from one activity to another. Divided attention involves being able to focus on more than one thing at a time. It is important to determine which type of attention is impacted to gain an understanding of the child's difficulties. Due to a combination of confusion, forgetfulness, and unwillingness to appear impaired, an individual will fabricate ideas that are partly or completely false. Bits and pieces of real or formally understood information may be incorporated into a story that the person truly believes. Brain injury often results in difficulties with regulatory control. These difficulties may be expressed as problems in the areas of distractibility, disinhibition, emotional ability, and emotional flattening. Changes in cognition contribute to changes in emotional regulation, behavior, and social skills. The ability to think flexibly often makes a student argumentative or unmotivated. Students often are unaware of changes in their abilities and do not pick up on cues from others. As a result, the student with a brain injury may be labeled as bad or behaving poorly, when really he just lacks the underlying skills necessary to demonstrate better behavior. Psychosocial difficulties are the most troublesome of the traumatic brain injury residuals and are sometimes more disturbing to families than the child's cognitive deficits. Unfortunately, these problems persist and are not easily treated because they not only are related to the actual injury, but also compounded by problems with social relationships. Psychosocial difficulties fall into several areas, such as those mentioned here. A traumatic brain injury can significantly alter a child's ability to function independently pre-post injury. Greater dependence may be a residual of the constant caregiving that was required after the injury, or may stem from necessary restrictions from physical limitations or impaired judgment. The child's lack of awareness recognizing the limitations may cause the child to view parents and family members as unreasonably restrictive, resulting in serious family conflicts and possible acting out behaviors. After a traumatic brain injury, children experience significant disruptions to their friendships. Sometimes peers regroup and go on without the injured child. Also, it may be difficult to reconnect with peers due to activity limitations imposed by the disability, and the child and peers no longer share the same social experiences. For example, the child may not be able to return to sports, particularly team sports that require quick decision-making and organization skills. This causes a double loss for the child, a loss of a primary stress-reducing activity and the loss of a shared activity with friends. In addition, friends who rallied around at the time of injury may drift off if the injured child has behavioral problems or cognitive deficits. Changes in emotional reactions and in the way they are expressed are common following traumatic brain injury. Irritability and depression are prevalent, partly due to recognition of low abilities. After several years of unsatisfactory peer relationships, limited achievement, and failure of others to recognize the cognitive deficits that are hindering functioning, some students give up trying, which has been referred to as a catastrophic reaction to failure. In most cases of traumatic brain injury, there's a sense that the self has been changed, that the injured person is different from the way he or she was before. Sometimes the individual does not fully understand this change, and in some situations, it may only be the family who senses the child is different. Back in there's a myth that once the child physically has recovered, that they have recovered completely cognitively. However, the reality is the cognitive and behavioral effects of a brain injury can last long after a person heals on the outside. Now we have a video that's going to take you from the time of injury until recovery of a young girl.
It was a Monday morning. I was going about my business, and I even heard the sirens. But it never occurred to me that there could be a problem.
When we got to the intersection, we noticed that there was something just out of place. You could feel that it wasn't a normal accident.
Then a few minutes later, I heard another round of sirens. And it even went through my mind, oh, it must be bad. And still, it never occurred to me.
The doors had been smashed in to the point where you weren't going to be able to open them.
The police pulled in and told me, that we had to dock.
The first thing that we had noticed was that Tim was deceased. We could tell that pretty quickly. And then we then focused our attention on Sarah.
They can call us from the scene, so the minute that the EMS provider is on the scene, we are at the scene with them.
Being that she was a pediatric trauma patient, we immediately, automatically, all of us know that we need to thank Johns Hopkins Children's Center.
The police officer got a call and said, we really need to go. And he said, it's critical. We need to go.
The ride to the hospital was scary. None of us really knew how it was going to turn out for Sarah.
I assumed we had lost Sarah too. Or that I was just going to say goodbye.
I just assured her and held her hand, and I said, I promise we were doing absolutely everything that we can for Sarah, and that if any place could save her, it was the Children's Center.
You're terrified. I have just lost my husband. And it was very hard. We were very close.
Within a very short time, we knew that she had primarily major skull fractures and some neck and brain injuries.
She had a dislocation where her skull connects to her spinal cord.
This is really a very, very serious fracture. Any pressure, any movement of any bone that's loose there had the potential for really causing catastrophic paralysis.
There had been, just a few dozen documented cases of people surviving this injury.
About a week later or so, surgical plates and screws were placed in to these loose fragments to fix them to both the base of the skull and to the neck.
Everyone at Hopkins was just fabulous about holding our hand and getting us through it. I don't know what I would have done without them.
The result was wonderful.
I went in that day and leaned over and was like, hi Sarah, it's Mom. Can you say hi, Mom? And she just mouthed. And so that was the real turning point for us.
I remember playing bingo, but I had to sit up to do it, and so apparently I really wanted to play bingo.
And I can't say enough about the nurses.
There was this nurse, and we'd watch, I just remember watching movies. A few nights I'd watch Hannah Montana the movie repeatedly. I watched it 5 times in a row, just not stopping.
The first day when she came home, it was awesome to see her coming home with the halo, riding in the car and being home with all the family for Thanksgiving.
But she worked so hard to come back. I think that the loss of her father was so overwhelming that whatever happened physically to her didn't even matter to her.
And I was on my tippy toes. Okay.
She's pretty much back to normal now. Doing everything she can do and playing and everything like she used to.
I'm feeling great.
I think Johns Hopkins Children's Center had a lot to do with that. And I don't think that she'd be where she is today without them.
No, you skipped me.
Looking back a year ago, it was hard to sort of believe at that point that this would be the outcome and that she's really recovered so amazingly.
I would definitely have to say that Johns Hopkins Children's Center is amazing.
If it had not been for a facility the caliber of Johns Hopkins Children's Center, I don't know where we would be right now. And I am so grateful to everyone there.
Well, the doctors are great, and they're just so nice, and they're really good. I think, I don't know how much training they went through, but they are really good. And look how I am now.
I am so grateful to all of them for giving me my girl back.
This final slide describes the barriers a middle school student had returning to school after a brain injury. Physical, he had problems with gross motor sequencing and balance, diffuse ataxia, and tremor affecting fine and gross motor. Cognitively, he had some problems with memory, learning new information, slowed processing, sustained attention and concentration, executive functioning, and organization. Behaviorally, he was very disinhibited. What he thought of came out of his mouth. He was sexually impulsive, really didn't have a screener. And emotionally, he was anxious, which he displayed through constant talking, had some anger, and a sense of loss. How do you think these difficulties would impact this student upon returning to school? At the end of this presentation, we have provided several slides that you may find helpful. This webinar is one in a series of 8. We encourage you to access the additional webinars in this series. Webinars and other great resources can be found at these sites. Thank you for joining us.